So through that very hole that we created, we are just going to have the wire going through. So let's look to see what we have in this view. In this view, we have a first transeptal sheet. This is going to be the wire of the second transeptal. Where is the rest of the assembly? Right there in the right atrium, waiting to go back to the left atrium. They're sitting there, dilator inside the sheet, sitting back into the right atrium. So what we are going to do right now, we are going to do anterior tilt with the ice, which will bring the tip of the ice towards the wire. Let's look how we are going to see this one, but on our echo machine. So this is the tip of the wire. That tip of the wire is supposed to go the tip of the ice right there. So it means that I have to bring the ice anterior tilt and bring this tip towards the wire, correct? But as you notice, these two dots are never going to move. The ice is always going to be here. So what you are going to see instead, you're going to see that the wire is going to go towards this very dot. So when you see that as you are doing the anterior tilt, you would appreciate that this wire is getting slowly closer to this dot. Let's look at it. This is a wire going up towards the dot. Right there. Still wire is here, dot is here. So I have to do a little bit more anterior tilt to bring this one to here. Right there. I just made it. And then I go to the left atrium. So if you appreciate here, you can see that this is my ice catheter. Actually, like about 3/4 of it is inside the left atrium. 1/4 of it is inside the right atrium, because this is a septum. So you can see those two dots again, left atrium, right atrium. Some part of it is inside the right atrium. Now I'm completely inside the left atrium. I go down counterclock majority of time at this stage, go down, watch my wire, find my wire, and advance the sheet and dilator over it, and pull back the dilator and the wire. So my sheet is now inside the left atrium. So now I would be able to see the ablation catheter going through the sheet inside the left atrium. Let's see what really sometimes we really have to do. I said I do it routinely, but let's look at this. You can see the septum. This is a needle. But if I ask you to show me the left pulmonary vein, it's going to be almost impossible to show it. And the reason it is that because of the lipomatous hypertrophy of the septum. So if you notice here, as this wave of the ultrasound waves are coming, they are going to deflect. They're not going to go, they're going to go back. They're not going to penetrate through that lipomatous hypertrophy of the septum. But if I just go and advance the ice inside the left atrium, this is the very same patient that now you can appreciate that you can see the left superior pulmonary vein, you can see the left atrial appendage. If I go ahead and start moving I can just start looking at the left inferior pulmonary vein, and then when I'm going to further clocking it, I'm going to see you almost always would be able to see the longitudinal aspect of this vein. So this is the right inferior vein. This is the right middle pulmonary vein. And if I clock it more, you're going to see the right superior pulmonary vein. Let's look at it one more case. Again, this case, I went to the left atrium. Here you can appreciate, I can see here the left atrial appendage. Then you're going to see the LAD and left circumflex arteries right here. And if I go down counterclock it a little bit more, you can very nicely see the left main from the left atrium, and that is the left coronary cusp. Okay, now we are going to start performing some catheter ablation. Let's talk about catheter ablation of atrial flutter. This is a slam dunk case when you see this, because there is nothing, there is no pouch, there is no eustachian valve. I wish I could tell you that I see this often. I really don't see it often. This is maybe 20% of time I see that. The rest of them, I see a lot of abnormalities. So here you can appreciate that I start burning from the tricuspid valve junction and the CTI. I'm pulling the catheter back towards the CTI and IVC junction. So very nicely, maybe a 2-minute burn, and almost always you have a very nice, conduction block. But here there is another issue. If you notice that there is a pouch there. So if I'm not going to see the pouch, chances are that I'm just going to come back and not going into the pouch. But when I see the pouch, I try to steer it towards that floor of that pouch. And as I do that, you can appreciate that the tachycardia terminates as soon as I go inside the pouch. There is another case that actually I did couple months ago, very interesting case. This is ablation catheter. If I'm going to pull back this ablation catheter, let's see the trajectory. The trajectory is this way. It's coming towards the IVC, like from here to here. But what am I going to be missing here? What I'm going to be missing here is that very structure, which is that pouch here. So I would not be able to burn this area. So if I'm pulling back the ablation catheter right there, you can appreciate that this is coming back, but I'm going to be missing this area because it is going to come back like this all the way to here. I'm going to be missing that area. But if you would be able to see it very clearly with your eyes, what I would do this candy cane. I perform a candy cane with this catheter. So make a U-curve and go inside that very pouch and finish the procedure. And almost always, if you don't go there, chances are that you're not going to be able to get that CT smooth block. A eustachian valve, Paul showed very elegantly today. So here you see that you can see that heart. This area is going to be very hard to access with ablation catheter right there. And this is the eustachian valve. And many times you really have to burn all over this eustachian valve because it contracts and you see a lot of electrogram on it. But if I'm going to ablate it from here, I'm going to come back here, but then I'm going to be on the air because this is not going to let me, this eustachian valve is not going to let me to get to this area. But if I see it, what I can do a continuous ablation. This is a continuous movement. It is not movie after movie. This is continuous movement that you can appreciate that you perform again another candy cane here, like a reverse candy cane kind of, and you continue the entire area to the very end, to the very last minute. So you can perform here. You can see that I'm right exclusively on the eustachian valve part of it, and we perform and finish that with single catheter ablation. This is a very interesting case. Perhaps you guys are the very first ones are seeing this. I just added this a few weeks ago. This is a case of parahesian. I wanted to show you how it is nice to be able to use eyes for that as well. Interestingly enough, you see that the transition is almost in V3, but I assure you that this was parahesian. I'm going to show you. So we know that this is the region of the his, and you can see this is my HD grid. And I make an open window, which means that I look through both atrium. This is my mapper, does map both A and the V. So my catheter is through the tricuspid valve. Half of it is in the A, half of it is in the V. And of course, I try to get this entire area. And when I do that, you can appreciate that this is my mapping system that's showing a very nice, fast activation through this very area, which was very close to the region of the his. And I have been using cryo for about 17 years now, and thank God we have never had any issue using cryo. But here, you can appreciate that this is my ablation catheter, cryo catheter. You can see A and B. I don't know if this is a potential or not, but very close to each other. But at the same time, you can see that I'm touching the his catheter. You see this yellow one is the his catheter. I'm touching it. You see the artifact. And here you can see that that is a very cryo catheter comes to the region of the his. And later on, you're going to see just the ice ball is going to be starting there. But let's look at this. So we start here. You can see that this is some artifact here. So we went cryo on. We don't do mapping or anything. I just go cryo on. If I don't terminate it within 10 seconds, I redo it, I reposition it. If I mean that if the accessory pathway doesn't go away. So here you can appreciate that, interestingly enough, look at this one. Within 7 seconds, the accessory pathway went away. But you can see very interesting thing. You can see the his on the his and the his on the ablation catheter. But again, if you are using cryo, as long as you keep looking at that and there is absolutely no increase in AH, so you would be able to immediately come off and you're going to be fine. So here you can see the ice ball here. And here you see now we got adhered. That time we were just not even adhered. So it was about maybe some degree close to 0 or so. And here, as soon as we are done, this is after the ablation, you can still see a very nice hiss on the ablation catheter. And this is what happened, interestingly, about 4 or 5 minutes ago. That is what you see, AH prolongs, and you have the block. But please don't panic. Actually, the reason this happened, I gave 18 milligram of adenosine. I always give adenosine just to make sure that the pathway is not coming back. So 17 years of using cryo, thank God we haven't seen any block, but with the anterior septal accessory pathway and parahesian, it is very forgiving. And here you can see that here it is where actually you see that the accessory pathway was gone within 7 seconds. Now we are going to switch the gears. We are going to talk about ablation of A-Fib.
Mansoor, I'm sorry to interrupt. There was a question maybe you could answer before moving on. There was a question about candy caning your catheter for a CTI ablation. How do you do that just with ice? I think it sounds like, you know, most people are more comfortable watching that on fluoro, especially as you turn it around. So how do you do that with ice?
Excellent question. Yes, basically, so if this, I'm going to be showing it this way. So this is a CTI, this is ablation catheter. You just bring the ablation catheter into the CTI and you start gently pushing, and as you're gently pushing, you just go and curve it completely. Sometimes you can come towards the region of the hiss and curve it completely, but you have to be able to see it on ice. So in my lab, interestingly enough, the ice is in front of me and my mapping system is on my right-hand side. So I look at the ice almost 99% of time for everything and 1% or 2% on my mapping system. I'm so used to using ice. So you want to make sure that you position your ice catheters somehow inside the right atrium, that at all the time you're able to see the ablation catheter. So you want to put it in the home view, and you don't want to see a shadow of the ablation catheter. You want to see the ablation catheter very bright. Means that all the waves are going through the ablation catheter, means that the ultrasound is nicely in the same angle with the ablation catheter. And by just looking at your ablation catheter, you just go ahead and slowly, either you go over the CTI isthmus and put a little bit pressure, and because it is pretty thick and you're going to be fine, or you just can go towards the hiss region. And sometimes when you do that, it may want to go inside the right ventricle. And should that happen, if you're using the FJ curve, maybe the best thing is that to use the F curve as opposed to J curve, so it doesn't keep going into the right ventricle. But should that go to the right ventricle, you can make it entire curve, completely curve, and then you pull back from the right ventricle and let the curve go. So you would be able to get the candy cane sitting on the isthmus.
Great, thanks.
No problem. So I'm going to show you some basic LA anatomy to help with ice movement. The reason I'm showing you this is the use of the ice. Remember, we put the ice inside the left atrium, so during the A-Fib ablation as well. So let's look at it. This is my mapping system. And here, if you appreciate here, you can see the left superior, left inferior pulmonary vein, right atrial appendage, right superior, right inferior. Let me go inside this structure and show you from inside, because the ice is inside. So we are going to, as if you are looking at the ice, I want you to understand that image is this way. Left superior and left inferior pulmonary vein, correct? So if I go ahead and counterclock my ice catheter, as I'm looking at the left superior pulmonary vein, if I counterclock my ice, I'm going to see this structure. If I counterclock it too much, I see the left atrial appendage. But if I counterclock it enough that I don't see the left superior pulmonary vein, neither I see the left atrial appendage, I see this very wall. So that wall I would be able to ablate. And that is the anterior part of the left superior pulmonary vein. So if I'm looking at the left superior pulmonary vein, I'm just looking, we are going one vein at a time. If I clock my eyes, I'm going to see the posterior part of the vein. I don't want to see the vein. I just want to see the antrum of the vein. I want to see a wall. I'm going to show you on the eyes. And I go ahead and ablate that area. So I know exactly I'm not inside the vein. I'm not burning inside the vein. I'm burning the antrum side of it. If I go ahead and continue clocking the eyes right there, what am I going to see? I'm looking at the posterior wall. I just want to hold it here. Remember, imagine that you are standing in the left atrium. You're sitting on the mitral valve and looking at the posterior wall. If you always think, and while you're doing this procedure, you imagine as if you're sitting on the mitral valve. You're looking at the posterior wall. So this makes the movement, the maneuvers much easier, because while you're sitting on the anterior valve, you're looking at the posterior wall. If you look at your right, means counterclock it, you're going to see the left superior pulmonary vein. Counterclock it more, you're going to see the left atrial appendage. If you keep clocking, you're going to see the posterior wall. If you keep clocking more, as we see here, you're going to see the right pulmonary vein. You're going to see the posterior wall and more posterior wall, and I'm going to see the right pulmonary vein. If I clock it more, keep clocking, and now we are going to be able to see the right pulmonary veins, and this is the right upper and the right lower pulmonary veins. And we observe one pulmonary vein at a time. So this is the right superior pulmonary vein. Let's look at the right superior pulmonary vein. If I continue clocking my eyes, I'm going to see the anterior part or septal part of this right superior pulmonary vein, correct? Because I clocked it. So I burn it there. If I see the right superior pulmonary vein with the eyes, and this time I counterclock my eyes, I see the posterior wall of the right superior pulmonary vein. I don't see the vein. I see the wall posterior to it. So let's look at it. We are doing an ablation of left superior pulmonary vein. Let's look at it. This is the left superior pulmonary vein. My ICE catheter is inside the left atrium, as you notice here. I just went ahead, I clocked my ICE catheter. So when I clock my ICE catheter, I don't see the left superior pulmonary vein. What do I see here? I see that antrum of the left superior pulmonary vein. So I just need to put my ablation catheter there and burn that very wall. From here to here, I'm done burning the posterior aspect of the left superior pulmonary vein. I know I'm not inside the vein because you cannot see the vein. You just see the wall. You were seeing the vein before you clocked your eyes. So since you clocked your eyes, you just see that wall, you do not see the vein, and you can see there very nicely, you can see that how tissue reaction here, and so it is going to be pretty safe. Of course, you are going to see here, of course, you have this one, it would help you, your mapping system, that you are in the posterior wall, and here majority of time, almost always nowadays, I go 50 watt, but I do not stop because I look at it with eyes. We continue burning. I keep moving. If the temperature probe of the esophagus shows the temperature is going up, I just go anterior. I keep burning. I go somewhere else, but I know I'm going to come back there. And I have the memory of it. I know where the ice is going to look like, where I would come back here, there again. So here is the left superior pulmonary vein. If I go and counterclock my eyes, what am I going to see? I'm going to see a wall, that wall. You see, I am neither seeing the left superior pulmonary vein nor seeing the left atrial appendage. I am just seeing that wall. That wall is between the left superior pulmonary vein and the left atrial appendage, right there. And ablating that very wall. And you see that ablation, you always want to see very bright. And here, if you notice here, if I clock it, I see the vein, but I don't see my ablation catheter because my ablation was anterior to the vein. So if I go and counterclock my eyes, I would see the ablation catheter right there. You see, that's the ablation catheter. So now if I go and counterclock my eyes, I would not see the ablation catheter. I would see the left atrial appendage. So I'm between these two structures. I'm between the left atrial appendage, left upper pulmonary vein, and these two my thumbs are the area that I'm burning, is the ridge between those two. And we are just burning here. So you can appreciate here, we are burning actually, this is a Coumadin bump, kind of where the ligament of Marshall goes through the ridge, left atrial appendage, left superior pulmonary vein. This is the ridge, and this is the ablation catheter sitting, and you can see how nicely I know that where I am burning. Sometimes I just go to the other side, and you have to burn on the appendage side of it, because remember, this is all, this area has to be majority of time ablated, right there. This is the venous side of it. Again, this is another case. You see my mapping catheter is inside the left superior pulmonary vein. Here I'm doing the carina between the left superior pulmonary vein and left inferior pulmonary vein. And this is the carina. Here you can appreciate again, left superior, left inferior, carina. This is the ablation catheter. And of course, I have my mapping system as well. And I know I'm in carina. So we are looking at both images at all the time. So right inferior pulmonary vein, another example, this is right inferior pulmonary vein. So this is a right inferior pulmonary vein. Again, now that I am seeing the vein, I'm neither posterior nor anterior. I'm just at the roof of the vein. If I bring the ablation catheter down here, I'm at the floor of the vein. I'm neither posterior nor anterior because I see the orifice of the vein. Exactly right there. I just brought the ablation catheter to the inferior part of the right inferior pulmonary vein, release the curve, going to the superior part of the right inferior pulmonary vein. Superior part,